let's move finally in this section to treatment options for first line. We have a new FDA approval for a monoclonal antibody for first line for squamous cell. I would argue that first-line regimens, there's competing strategies. We've got cisplatin gemcitabine, the histology story woven from the very large study comparing cispem versus cisgem. We've got carboabraxane showing response rate in a subset analysis north of 40% from data when it was compared to carbotaxol. We have carbotaxol. We also have cisgem nesi. These are all options here. Mark, I'll turn to you first. How do you distill this all down, and what do you do in clinical practice?
So to me, again, old school, cis would still be the basis. And then what you add with it, we really don't have good data. If you want to add a taxane or you want to add gemcitabine, I have to say that I think both of them are reasonable choices, and it's really hard to tell them apart. If I had to add a taxane, I'd add albumin-bound paclitaxel. Basically because of the hypersensitivity problem and the need for the extra steroids. It just kind of takes that away. And I think the data is that it's clearly no worse. Some people might say it's better, and I would go with that. But I think it's pretty hard to tell cisplatin taxane versus cisplatin gemcitabine.
Okay, and what about nesi? Where do you see nesitumumab fitting into all this?
Well, then we're going to get a little philosophical here. Okay. You know, the drug is approved in the United States. The benefit in overall survival upon which the approval was based is approximately 1 month. A few years back, that 1 month wasn't enough to get cetuximab approved. Suddenly it's enough to get nesitumumab approved. And it is a month. It is what it is. And it's a tough call. I'll have to say at my own institution, most of my colleagues have not chosen to give it.
If there was a reasonable...
I give it, by the way.
Okay, okay. If there was a reasonable...
Of course you know I give it.
If there was a reasonable molecular enrichment strategy. We've seen some hints about H-score didn't seem to pan out. We have some EGFR copy number by FISH perhaps being predictive of outcome. Would that sway, I guess you use it, but would it sway your institution more?
It would help. But you know, I think it ultimately boils down to your pact with your patient. You know, some folks ask very clearly for this kind of any additional thing that can be added despite the toxicity, which is real, and despite the lack of a huge benefit. And for those patients, it's okay. For other patients, it's not okay. And the other things, as Sarah brought up too about the hair loss, I mean, to me, that's a big reason to try a gemcitabine over a taxane for a lot of different patients. Other patients don't really care. And you just have to get their advice on that.
Sarah, your thoughts?
Yeah, I mean, I brought this up earlier and got kind of, you know, the schedule is important. You know, the nab-paclitaxel and gemcitabine are weekly, whereas paclitaxel is every 3 weeks. I'm not trying to keep patients away from me. I'm happy to see patients as often as they want to come, but the sense is that patients are happy to only have once every 3 weeks. So, you know, when you don't have, you know, survival benefits, or you don't know if there's a difference, is a every 3 week schedule.
Can I tell you a secret?
But it's something to discuss. I guess it's a point for discussion with patients. If you know, weekly is hard for them, if they're coming from far away, it might be something to consider a regimen based on that.
The next, take your patient who you treated weekly or every weekly, and then over 3 months, see how many doses they got. They got the equivalent of 1 dose every 2 weeks. That's what they got.
Coming in to try to
get
the doses.
But not if you give them 1 dose every 2 weeks.
So you adjust the schedule.
Absolutely.
So that's a different story, right?
Yeah, but if you give the 1 every 2 weeks, you give the same amount of drug if you give that usual day 1, day 8.
And it winds up being that anyway with toxicity, so you I agree.
The same with the taxanes.
Yep.
And I have to tell you, one of the worst things for a patient is to come and not be treated.
That's right.
Particularly in New York City, where you have to pay $55 to park your car, and whether you get treated or not. And we can't take that back. But I ask you to look at that. If you don't think that you know, this is the right thing to do, that's what you're doing. And the same is true with the Braxane, by the way.
Right. So I think it's a part of it is the schedule and discussing that, and then part of it is the side effects. So thinking about nesitumumab and even ramucirumab in the 2nd line or 3rd line.
In gastric, you know, they give it every 2 weeks, and that's what I do.
And that's what it is.
Yeah,
but I think it's you know, toxicity discussion, schedule discussion. But when you don't have survival data, it's hard to say this is clearly.
Well, it works in I can't believe that it would work in gastric and not in lung.
So I think, again, this is it can't, I think you need to be the leader in making the decision, but this can elicit a shared decision-making talking to the patient. There are competing strategies. I haven't used nesitubimab yet. I would like to use it and try it. It is one of the only studies, to my mind, looking at a maintenance strategy in first-line squamous in combination with platinum. 10% of those patients were ECOG-2, which is somewhat representative of my patient population, so it's safe. But we've been very encouraged with the carbobraxine data, and we've had a lot of patients on clinical trials. So I think it is a discussion that you have with your patient, but I think the points are well taken on the panel in terms of how they approach this therapeutic decision.